Hi, everyone. We're back with another episode of Fertility Docs Uncensored. I'm one of your hosts, Dr. Abby Eblen with Nashville Fertility, and I am surrounded by my lovely and lively co-host, Dr. Susan Hudson from Texas Fertility Center,
Hello.
and Dr. Carrie Bedient from the Fertility Center of Las Vegas. Hey, everybody. So we were talking beforehand as Carrie was drinking some coffee and got choked on it a minute ago. We were like, so
It
what's
was
that?
not coffee.
Oh, it
Don't you
wasn't.
dare malign and slander me in such a fashion.
Well then, okay. So I just came up. Let's just talk about what's your choice. Are you a coffee person, tea person? Are you both? So
Or
tell us,
something
Carrie,
else.
or something else. Yeah.
So, in my personal, humble, and completely right opinion, um, coffee belongs in ice cream as a mocha flavoring only paired with chocolate.
Okay.
And it is acceptable to be found in, cupcakes and cookies and ice cream and other dessert type items. The occasional coffee rub on a piece of meat or something like that. But beyond that, it is completely inappropriate to smell or have around. And
Oh my goodness.
why would
Carrie,
someone drink motor oil?
we have been pretty good friends now for almost 3 years, and I never knew that. I didn't realize you were an anti-coffee person. Who knew?
So coffee of the month is
Wow.
not a good gift for Carrie.
Yeah. Dang. Oh
I mean,
man.
my husband gets coffee of the month because he has been a coffee drinker ever since I've known him, and he's like straight black coffee, no cream, no sugar, no nothing. And so he gets these, fun coffee of the month things.
Yeah.
And he always opens them and smells them, and he tries to offer them to me, and we're like, why? It smells horrible. Like, a true act of love in my
Wow.
household is me
Who
cleaning
thinks
out the coffee
coffee
grounds
smells?
from his coffee maker.
Who thinks coffee smells bad?
Even
That's
even my
crazy.
non-coffee drinking husband still likes the smell of it.
Yeah.
That is weird. No
Wow.
offense, Carrie.
Inappropriate.
Like, I don't
Carrie.
mean to call you weird, but it is a little
I think you got a
unusual.
gene. I think there's some gene for that or something. I think
It's
I
you're
like
mean,
the
like,
I've been called
cilantro
worse than
gene.
weird,
yeah, it's like the
but
cilantro gene. You're missing the coffee gene.
I mean,
Man.
I have only just recently found it acceptable to drink the super sugary loaded Starbucks drinks that are so masky in
About
the taste of
20,000
coffee.
calories for each cup.
Yeah, it's like 20,000 calories per cup, and the only hint of coffee that's in it is in the name
Yeah.
and in the caffeine load, which is the
Do
only
you
reason
drink
I drink it.
while we're on this and discovering things, do you actually drink tea?
I usually have a bunch of herbal teas. Like, I always have peppermint tea and chamomile
Oh,
tea in my
yeah, me too.
office.
Okay.
And I always have a stash at home.
Okay.
I happen to have apple cider in the house, and so I've got the mulling spices for that. And so
But
I've
do
been
you
drinking
drink
that
tea,
recently.
like true tea, not herbal
Well,
tea?
that's true tea. That's just a different kind of true tea.
I mean,
So
really, it's a
like
tisane, not a
tea
tea.
leaves, not chamomile, not like herbs that make your tea like pink or green. Okay, but like
What
black.
kind of pink tea are you
I'm guessing
drinking?
you don't drink tea.
No, I mean, I enjoy like an herbal tea, okay? But like I'm talking like if you went to London and ordered a cup of tea, would you drink that?
Uh,
Earl
yes,
Grey,
I would
yes.
drink that over coffee. I usually don't seek it out. I mean, I really do like the tisanes
Wow.
rather than the teas, but a really good Earl Grey I'll drink. There's some of the morning, blends that I'll
English
drink,
breakfast.
like some of the Christmas blends with the cinnamon and apple overtones. Like, those I will drink, but the regular tea is like, it's just not.
I'm curious, like, does this like when you I mean, we all know you have a sweet tooth. Like this all goes along with the whole like sweet versus bitter. Like,
Uh-huh.
do you generally have an aversion to like bitter, dry flavors?
She's trying to diagnose you, I think. She's gonna do some gene research after we get off here
I'm
today.
curious. I'm
Yeah.
wondering if it's like a taste bud thing, because when I'm hearing like you like anything that doesn't seem like real coffee or tea.
Yeah. Yeah, because I don't, and traditionally I have always avoided it for the caffeine because I mean, I'm 40 now, and I didn't drink caffeine really with any regularity until 39 and a half. Like it's really been in the last 6 months that I've regularly had some infusion of caffeine. And even then, that's not
That
consistent.
explains some
She
things.
avoided my conversation about food, though.
I don't like bitter stuff. I think
that's what
real.
it is. I think you just don't
real.
like bitter stuff.
Ah, interesting.
Interesting.
Well, I like both, but I put sweet and low in both of them. So I mean, I sweeten them up. You can make them sweet.
I love Southern people who put sweet and low.
Oh, sure. Splenda, sweet and low. Come on.
Do you know the remedy for hiccups where you eat a teaspoon of sugar to make them go away?
Right.
No.
When I was a kid, I was in an airport and I had the worst hiccups. And so I grabbed a sugar packet and downed it. It was not sugar. It was sweet and low. And I thought I was going to die. It was awful. Do not recommend. 0 stars.
Okay, so now that we spent the whole time on Carrie, she's neither coffee nor tea. What are you, Susan? Coffee or tea or both?
So I preferentially drink coffee. Like I like coffee that has a good, robust, strong flavor. I put cream in it, no sugar. Like lattes and stuff. I do like plain lattes, things like that. I will drink tea. I do prefer my tea with cream too. But if I have a choice between the two, I'm not like adverse to tea. Having celiac, there are some teas that have like additional flavorings and stuff like that. So I have to be real careful that there's no gluten or anything like that. So I tend also to coffee because it's relatively safer for me to get. So
you're saying you like things that appeal to your dark and bitter soul.
yes.
Got it. Okay.
Yeah, Colin, your bitter soul.
As long as we're clear here. Got it.
Yeah.
Okay.
What about you, I like 1 cup of coffee in the morning with Splenda and lots of cream. And then in the evening, I drink like chamomile tea or something like that. And my daughter did get me the Tea of the Month Club last year, but the problem is a lot of that has caffeine in it. I just don't want to drink that at night. But so I do both. I like both in the same day. Excellent. All right. Well, boy, that was a little more controversial than what I thought it would be. I thought that was when I came up with the topic, I thought it was kind of stupid, but actually we learned a lot about each other, I think.
Let's go. You ready to do a question?
Yeah. Before we move on to our topic, Susan has our question.
All right. Hi, Fertility Docs. Thank you so much for reading my question. I've been binge listening for the past 2 weeks. She's listened to 80 episodes in those 2 weeks.
Gosh.
Oh my God, that's amazing.
Oh, wow.
And the moral of the story seems to be age. I'm 39 with a 2 and 3-year-old, and we started trying again 10 months ago with 2 missed abortions ending in D&C. We are embarking on the IVF journey, assuming that these were probably both chromosomally abnormal embryos, but have not gotten labs yet to rule out other problems. My question is this: how much variation about the mean is there when it comes to fertility in general and ovarian reserve by age in particular? To me, it seems like very few things in life and health are as certain as the statistics that are often given for each age group. Thanks.
There's always someone who is in the 2 standard deviation greater
right,
or
the 5th
lesser.
percentile, yeah.
Yeah, like there's always someone in the 1%. And as the deeply classic and important social commentary movie Dumb and Dumber has noted, is that, you have the chance of a snowball in hell of dating me. And it's, so you're saying I have a chance. And that holds true with fertility, because there will always be someone who is in that upper 1.5 to 2 standard deviations above the mean who's going to do great. Like there is a reason that people have spontaneous pregnancies. I mean, 49 is the oldest, no, 50 was the oldest patient that I ever took care of who had a spontaneous pregnancy. So this stuff happens.
But that's not normal.
It's not normal.
Common. It's not normal. And the likelihood of you being in that group is really small. But if you're in that group, it's fabulous. And also there are criteria where people going through IVF who have really low criteria for follicle count and AMH and all of those things, sometimes those people conceive naturally just fine. And you've had two missed abortions or spontaneous miscarriages. And so that means sperm and egg are coming together. So it's, can you play the game long enough to get a good matchup that works? And IVF can help speed that along, but it's not the end all be all. And so really it's what kind of gambler are you, and how do you like your statistics, sweet or bitter? Like, you either have the 1% chance of succeeding or the 99% chance of not, but you are not going to have 1% of a baby. You will either have the baby or you won't. And so, the fact that you're getting pregnant is a huge.
Well,
And had two successful
39.
pregnancies in the past.
She's had 4 pregnancies. She has a 2-year-old and a 3-year-old. So I would argue that you are a little different than the average patient we see. So therefore, I can already tell you you're not the average patient that we see. The other thing too, it would be interesting to know what your AMH is. Not that AMH can offset the age component, because the age component really speaks to the genetics. And so you're right, probably the miscarriages that you had, very likely 40% chance probably were due to a chromosomal abnormality. But we do find, particularly with IVF, if somebody has a high egg number and makes a bunch of eggs, if you were to do something like IVF, the beauty of that is the more eggs we have, the more we can test, and the more likely we are to find that, one embryo that's genetically normal for you. So I really would think a lot about IVF, particularly if you have a good egg number. And even if you don't, like Carrie said, every now and then we'll find somebody, even with just a small number of eggs, that ultimately ends up going on and finding one that's normal, and they get pregnant with that one.
Yeah, one of my rules is I never say never, because I've seen never happen.
That
I
is
don't know how many
exactly
times,
right.
like some other doctor would tell somebody that they were never going to get pregnant, and they come in and see me for a consultation, and then they like get spontaneously pregnant. And I'm like, I love to take the credit, but
Yeah.
that we're happy to get you pregnant no matter how it happens. But exceptions are that,
Yeah.
I mean, and we hear news stories about like amazing celebrities who are getting pregnant at these like incredible ages and things like that. What I have to say is you are getting the spin of the story that they want you to hear. Okay. And not necessarily the bitter truth of everything else that they've gone through. And, exceptions do happen. Otherwise, it wouldn't be the world we live in, but most people are going to be normal for their age.
Yep.
All right. So we're going to talk a little bit on this episode about endometriosis and infertility. So Carrie, you want to start us off and tell us, what is endometriosis?
So endometriosis is tissue that should be lining the inside of the uterus that has set up shop and made a home outside of the place where it should be. So there are a couple theories of how this happens. One is a retrograde menstruation theory, where everyone, when they have periods, most of the blood is going to come down and out through the vagina, but some of it's going to go up and through the tubes and go into the peritoneal cavity. That's why when we do laparoscopic surgery on someone who happens to be having a period, you can oftentimes see a little bit of blood pooling in the bottom of the peritoneal cavity. And so that's one potential theory. There's an ectopic implantation theory or a migration theory, where it didn't move to the correct place when everything was forming. And so instead of 100% of it being lining the uterus, there's little implants here and there. And then there's also an immunological theory, where it's that the function is totally normal. You have some blood that goes into the peritoneal cavity, and that's normal and expected, but the immune system's response to it is completely inappropriate. And so instead of clearing it up and just, cleaning up in its little dustpan and then throwing it out with the trash, it sets up shop, and the immune cells that should be clearing it up, instead of just like very kindly asking it to leave the bar, they get into a full out brawl, and the whole bar gets destroyed as a result of these two cells not talking nicely and just taking it cleanly outside.
So Susan, how does that interfere with infertility? What does it do? She's cracking up at Carrie right now.
Oh my goodness. I love Carrie's explanations. It's great. It's great. So I kind of think of it in 2 categories. It can have an effect both structurally, and it can have an effect kind of chemically. So I'm gonna take structural first.
Okay.
So when you have endometriosis, you can have these implants actually anywhere in the body. They are most likely to happen on the surface of things. However, we can see endometriosis in ovaries, which that's the one time we can see endometriosis on ultrasound. And you'll have a follicle that, instead of being full of clear fluid, is full of blood. essentially. And when we do surgery and we open it up, we call them chocolate cysts because it generally looks like old blood and it looks like liquid chocolate.
And because gynecologists and physicians in general are known for ruining food.
Yes.
By comparing them to bodily functions. Sorry.
Exactly. So this endometriosis, like I said, ovaries, it can be on your tubes, it can be on your uterus, it can be on your bowel. In rare cases, it can be in even distant places in your body, like in your lungs or your brain. Those are really, really unusual, but we do sometimes see those.
Mm-hmm.
And when we see it on those surfaces, you think about it when somebody has surgery and incisions get made, essentially those surfaces are abraded. They're not the healthy, smooth, non-contact surfaces that they're meant to happen. And adhesions form. And those adhesions are essentially scar tissue. And those adhesions can disrupt the normal flow of where things need to be. So sometimes, so your fallopian tubes are very delicate pipelines that within them, they have little projections that help egg, sperm, embryos, everything move to the right place. Those little projections can get damaged. The ends of the fallopian tubes can get, essentially blocked or have an abnormal shape. Sometimes when you have an HSG, a dye test of the fallopian tubes, we'll note that the ends of a fallopian tube can look clubbed. So like the end of a club, it's nice and smooth instead of being feathery. The end of a fallopian tube's called fimbria, which is essentially a Latin word, I believe, for feathers or fingers. And so that's really kind of structurally how it has its biggest impact.
And so chemically, how does it have an impact?
Chemically, that endometrium is producing all kinds of stuff that is not making it friendly for eggs and sperm to get together. And so that's really where things have a big impact when we need to be more advanced in our therapies, especially for people who have advanced endometriosis, in being more aggressive and doing things like IVF, because we can take egg and sperm outside of the body, let them really create a good healthy embryo and have a good foothold on progression before putting it back into the endometrium at the right phase where it's going to nestle in and not have that negative effect.
So Carrie, what kind of symptoms do people have when they have endometriosis? What's the gamut? There's a whole big gamut. What's the gamut of symptoms they can have?
The gamut is nothing to everything.
Yeah, that's what I was trying to get you to say. Yeah.
And the reason for that is, though, sometimes we have patients who have zero complaints and we need to go in to do surgery for some totally benign, unrelated reason. And we get in there and it looks like someone has taken a jar of rubber cement and just poured it all over and then taken like a blowtorch and solidified it and then put just another layer of glue on top of it. And the patient feels totally fine. We have other patients who come in and they are complaining of severe pain during their period, severe pain during their entire cycle, pain with sex, pain with bowel movements or urination, needing frequent urination, everything in the free world. And you go in and sometimes you see the rubber cement and glue scenario, but sometimes you really don't see hardly anything. And you look in and you see like, well, there's a tiny little bleb, there's a powder burn, there's a little erythematous or bright red spot, and those look like endo, but overall things look really pretty clear. And if you didn't know her history going in, you would say, oh, this is a completely normal pelvis and we don't see anything. And so the symptoms can really be pretty widespread. And then you've got some of the really weird things like, the catamenial endometriosis, where every time someone gets a period, they have bleeding in their lungs because there's a little implant of endometriosis that has made it up to their lungs or their diaphragm or some other completely inconvenient place. And they have symptoms from that. That is not normal. So please don't think the next time you get a winter cold and you get a bloody nose of, oh my God, I have endometriosis of the nose. That is not what I'm saying. Please restrain yourselves.
So is there any cyclicity to kind of when people have symptoms with endometriosis, or do they have it all the time?
It can be both.
Maybe.
So the answer is yes. For both of those things are true. So there are some people who just have really painful periods and then their periods are done and it abates. There are other people who just have pain all the time. There are people who have pain with ovulation and with their period. Really anything goes, especially with bad endo. It's tough to correlate it just to the endo because anything is fair game.
So Susan, how's it diagnosed? Can we do it with
So
ultrasound?
if you have endometriosis in the ovaries and you have serial ultrasound, so you have multiple ultrasounds that show something that kind of has a ground glass appearance, most of those are going to be endometriosis. But with the exception of that, really the diagnosis of endometriosis has to be made by having surgery and somebody looking with a camera with their own eyes. And, it's something that in the field of reproductive endocrinology, we have definitely seen a change over really probably about 2 decades.
Mm-hmm.
I would say 20 years ago, if you walked into an RAI's office, there was probably about a 70+% chance that you were going to have a diagnostic laparoscopy, just to take a look. It's like, oh, you're here. Let's take a look. Let's look at your innards. And that has changed. And I think there's a number of things that have led to that change. And nowadays, there are still some places that do quite a bit of diagnostic laparoscopy, but I would say that is becoming more and more the exception.
When you say diagnostic laparoscopy, what do you mean by that?
So first of all, laparoscopy is a surgery where we make small incisions at the belly button, usually 2 or 3 other little incisions, and we put a little telescope instrument inside your belly, and we take a look. And so the diagnostic means, other than to take a look, we're not sure what we're going to find. Okay.
Yeah.
We may diagnose things. So that's why it's a diagnostic laparoscopy, to see what's there. And then if there's something there, to ideally do the best we can to fix whatever condition we might come upon.
So Carrie, you'd mentioned a little bit about kind of how endometriosis looks. Could you be a little more, go through that one more time with us? What do we see as physicians when we do laparoscopy and we're looking for endometriosis?
So there's everything from the mild end of the spectrum where you put your camera in, and when you take a look around, usually the tissue within the peritoneal cavity or the abdominal cavity tends to be a nice shade of pink. We're not talking about an angry red or a deep pink.
Pepto-Bismol.
Yeah, I mean, we're talking about just a nice, easy pink, and then of course you've got the yellow fatty tissue that surrounds and is protective of many organs. So
and
when you
shiny.
look, and it's shiny and it looks clean, like it looks like someone just took a hose and they washed the car, and it's got that kind of glistening, clean appearance to it. When you go in and you start to see a non clean appearance, if you start to see like, hey, there's little spots here, like this is more mottled, that's when you start to see that, okay, maybe there's endo here. And it has a huge range of what it can look like.
Mm-hmm.
Sometimes it looks like little clear blebs of little bubbles that are kind of locked into the surface where, I don't know if you've ever put a plastic film over something and you've gotten a bubble in the middle of it where it's like popping up. Sometimes it looks like that. Sometimes it looks bright red and very vascular and kind of angry looking. Sometimes it's a dark blue to black, what's called powder burn. Sometimes it's got kind of a white, very scarred down appearance. There's just a huge range. Sometimes with the case of endometriomas, it is a big chocolate fluid filled cyst that looks like a giant balloon that if you pop it, outpours Hershey syrup. Hope nobody was having sundaes for dinner tonight or after dinner tonight. That's a lot of the variation. The other thing that we can see is just incredible scar tissue. Normally everything in the abdomen is very loose. Imagine a bowl of spaghetti with some olive oil over it where you just jiggle the bowl and the whole thing moves very easily and the noodles slide around each other without any problem. Now imagine it if there's no sauce on it whatsoever, and it's just that starchy, been sitting out for 15 minutes kind of cold pasta where you jiggle it and it all moves as one icky, kind of weird unit.
No chocolate sundaes tonight. No spaghetti
No
for dinner.
spaghetti.
No.
Oh yeah, no. I mean, like I said, gynecologists been ruining dinner for decades. So everything just kind of sticks together. You know, sometimes you can see it looks like Halloween, where you know how you put all the cobwebs up and it just sticks everywhere. I mean, it's just like nothing moves the way that it should. It's all kind of jacked up and pulled out like they're tiny little ropes and cobwebs. And gauze holding everything together. Sometimes it's really thick, and like burlap that's in there holding everything together. Stuff is all jumbled together and squished. And there's really a very wide variety of what it can look like.
So Susan, you're doing
Sorry,
laparoscopy.
I'm so glad you asked Carrie this, because her variety of adjectives is unparalleled.
I think just the visuals that Carrie gives me are unparalleled. I can't do that when I'm talking to patients. Carrie's very good at giving interesting visuals.
It's great.
Oh, shucks.
My imagination runs away with me when she's talking. All right, so Susan, you're the surgeon. You're in there and you're like, yep, there's some endometriosis there. Yep, there's some there. Yep, there's an endometrioma. Are you going to go, okay, she's got endometriosis, sew her back up and tell her that the next week? Or what are you going to do when you're in there? Or what do you hope your doctor's going to do when you get in there?
So some of it is going to depend on the skill of the physician who is operating on you. Okay. And some people are comfortable in operating in endometriosis and some people are not. Okay. And since our listeners are listening, are all the way across the spectrum, if they've never been to see anybody, or they may be seeing their gynecologist, or they may be seeing a reproductive endocrinologist, it's reasonable to set up expectations. There's going to be some people who, if they go in there and they see a ton of endometriosis, they may know that is not where their skill set lies. And remember, our number one rule is do no harm.
First, do no harm. Yeah.
First, do no harm. And so you may have a surgery and they truly do a diagnostic laparoscopy. They look in there and they're like, oh my goodness, that is a lot. I need to get somebody else who is going to be able to take care of this person better. So there is a chance that, you know, we all have people come to our offices that have had those types of surgeries. Generally, if you're going to see a reproductive endocrinologist, we're probably going to be a bit more aggressive in kind of surgically treating your endometriosis. Now, and again, how aggressive somebody is going to vary from physician to physician. I think most of us feel pretty comfortable in cauterizing or burning superficial endometriosis. Some of us will surgically cut out and address endometriosis that way. If we have an endometrioma, generally we try to remove the kind of sac that was holding the endometriosis fluid, because that helps prevent recurrence. Lysing or cutting adhesions to help free things up. Now I'm sure we have all had those cases that we've done as much of that, but restoring full pelvic anatomy is not always possible. Okay. Because again,
and what do you mean by that? Full pelvic anatomy.
So, you know, when Carrie was talking about, you know, the spaghetti with the oil versus the spaghetti that's all clumped up. So sometimes the spaghetti that's all clumped up is so clumped up that if you tried to tear it apart, you're actually going to potentially damage things like the ureter, the tube between the kidney and the bladder, the bowel. So again, that stage of do no harm, we want to address and a lot of it has to do with where are you in your treatment and what are your plans? You know, if you come in and you're having a laparoscopy for whatever reason, and your partner has terrible sperm and we know you're going to do IVF, but you have no pelvic pain, you have no symptoms, like we just happen to be there for some other, you know, you might have a hydrosalpinx that needs to be removed. Okay. We're going to kind of deal with what is superficially there, but we need to not lose the forest for the trees.
So Carrie, to that end, is there ever a time, say, for example, you wouldn't jump right into surgery, even if you had a pretty high suspicion that somebody had endometriosis?
So at this point, a lot of the reasons for surgery, if someone is having pain and they need that addressed, that's a decent reason to go in and say, okay, is there something that's getting pulled, yanked, or otherwise discombobulated, such that we could potentially fix it by taking care of some of the scar tissue. So that is one good reason to go in and do surgery. The other discussions of whether or not to do surgery. So a lot of times endometriosis can cause a hydrosalpinx, or a really fluid-filled tube that does not behave normally, either or including both, of not letting the egg and the sperm pass to find each other and have their little party, or they can potentially pass and find each other, but the interior structure is so damaged that you're really worried about an ectopic pregnancy, implantation in the wrong place, and causing major drama that way. So we do tend to want to go in and remove hydrosalpinges when we can. And that's always preceded by a conversation of, look, if both of these are abnormal and I take them both, that's IVF for life in order to get pregnant. So there's a lot of pre-counseling that goes into it. There's big debate as to what you should do about endometriomas, particularly when you're looking at fertility treatment, whether that is
Size matters.
Size matters, location matters, accessibility matters. And so if someone has just a little dinky endometrioma, we're not going to go in after it, because by removing it, you are inherently damaging the ovary. And so you have to make the decision of, at what point do we want to say going in and removing that cyst is going to make a difference versus just cause damage and not really help a whole lot. And I say removing the cyst very intentionally, because just sticking a needle in and draining it doesn't do a whole heck of a lot, because you're just going to have that fluid collect the very next month and you have gotten nowhere.
And when Carrie's talking about damaging the ovary, what she's really saying, please forgive me for interrupting, but that every time we remove a cyst or cauterize something on the ovary, you are losing eggs. You are losing more eggs than what you would have naturally done. And because you're born with all the eggs you're ever going to get, that can have a huge impact, especially if you're in your upper 30s and early 40s, or if you just inherently have a low egg count.
So when we have people who've had a bunch of surgeries before, for example, I'm a lot less inclined to go in there and do anything until after I have those eggs out, until after we have a pregnancy, unless I have to go. Because I've had patients who have such huge endometriomas that I just can't access any tissue. And so that's got to come out, because otherwise nothing's going to grow. But otherwise, if someone's had a bunch of surgery, I usually try and err on the side of, well, can I get these eggs out? And then can we go in and deal with it?
And, that's something that's really changed for sure over the last decade. We used to, if somebody had a 2 or 3 centimeter endometrioma, we would definitely go in and take that out before we did IVF on them. And the pendulum has definitely swung in the opposite direction. And I think appropriately so, because when you cut into the ovary, you are going to take away some eggs. You're going to damage some of the eggs that are there. So one last thing, Susan, I don't know that we as reproductive endocrinologists really say that this is cut and dried or really use this a lot, but talk a little bit about staging, because people may see that in the literature, may see something about, I've got stage 2 or I've got stage 4. Talk a little bit about the staging and what that really means and why the staging system was really developed.
Right. So the staging system that Abby is referring to is a staging system that was developed by essentially I'm totally losing my words here. By ASRM, which is our national society. And technically, I think it was the American Fertility Society.
AFS,
back way before. And really, the purpose of the staging had nothing to do with prognosis. It had to do with physicians communicating to other physicians. And so there are these lovely little drawings that show us, what is stage 1, what is stage 2, and each of these progress to having more and more endometriosis in different places. But it was really meant so that if, I do your surgery and I say you have stage 2 endometriosis, like without even looking at anything else, Carrie or Abby already in their mind have an idea of, okay, she has this, she does not have this. So, these are things for me to think about. Or you have stage 4 endometriosis. That means something different than stage 1. And so like I said, it has to do with that communication. It has absolutely nothing to do with how much pain you have. Okay. And I would say there are studies that show that more advanced endometriosis, so especially stage 3 and stage 4, they tend to come back faster and with more vengeance. Okay. Endometriosis does tend to recur after surgery at the similar stage it was before. Okay. And we know that people with more advanced stage endometriosis are more likely to need more advanced intensive fertility treatments like IVF. But it's not a hard and fast rule. And I think a lot of patients don't necessarily, I can say early in my career, I did a lot more laparoscopy to diagnose endometriosis. And really it was for the purpose of like, oh, you have stage 4 endometriosis. We know the chances of you getting pregnant with something shy of IVF is very small. Because most people, at least in Texas, didn't have fertility treatment coverage. Regardless of what I said, they wanted to try lesser aggressive things to see if it would work, you know?
Yeah.
And I think we talked about earlier, are you going to fall into that exception? People want to know if they're going to be that exception. And so it really didn't help that many people make their actual path decision any different. And I think that's a reason why it hasn't become how it has become something we don't do quite as much as we used to.
So one last question. This is a little bit, I mean, there's not a real right or wrong answer, Carrie, but just, so if somebody has fairly mild endometriosis versus very severe endometriosis, what prognostic information could you give them after you treated them with surgery? I'm kind of making it a little challenging.
Like typically if it's really mild, not a whole heck of a lot.
Right. And I
mean,
think that's another reason why we sort of backed off diagnostic laparoscopy, because if somebody's not having a lot of pain, you don't see something on ultrasound, pretty low likelihood they're going to even have it. But if they do, and even if you get rid of it, the chances of improving their outcome is a few percentage points in a given month, and it's probably just not worth the risk to them with surgery. So I think there's a lot of good reasons why things have changed as far as not routinely doing diagnostic laparoscopy unless there's a really good reason to do it.
One thing I'd like to mention, as a surgeon, the best belly to operate on is the belly that has never been operated on. Okay. Every time you have a surgery on your abdomen, you're at increased risk of damage happening to something inadvertently. And so it's one of those things that, again, like Carrie, you probably didn't see it so much in your early career, but I know Abby and I definitely saw it. We would see people who had 4, 5, 6 laparoscopies before they would have even reached 30. And, you know, that's the, you know, I see that. I'm like, oh, I don't like that. That's just, you know, it's kind of setting yourself up for something dangerous to potentially happen without that much return. I mean, realistically, if you've had that many surgeries, that means you keep on having pain that keeps on recurring. And that's for a complete different episode.
Yeah. I was just thinking about that
for us to talk about soon.
Yeah.
So to that end, is there anything else that you guys want to add in that we didn't cover in this episode that you think our listeners may want to know about?
I would like to say that, you know, we live in an information age. Okay. Our listeners are listening to us right now because they want information. We like to, you know, Google, why is the sky blue? And, you know, people come in and they're like, do I have endometriosis? And a lot of those people, unless we've done a laparoscopy or, you know, you can see an endometrioma or not on your ultrasound, we're not going to have a definitive answer. But that doesn't mean our treatments don't work. Okay. And that's the reason why we're doing the other testing, the ovarian reserve testing, the HSG, your ultrasounds, you know, and so sometimes just realize that even though we may not have that piece of information, that doesn't mean that we're not addressing the possibility that endometriosis may be there.
One thing that's important to know is that a lot of surgeons, a lot of REIs, when you go to see them, if they say, you know, look, I think you need surgery, I think there's a fair amount of endometriosis here, I want you to go see my colleague XYZ, it's usually for a reason, because especially, and Abby and Susan, you guys have probably noticed this as well, but especially when you hit my generation of trainees, there was
Mhm.
already a division that had happened where the REIs were focusing on one thing and the minimally invasive surgery fellows were focusing on something different. And so we work closely together. I mean, I know exactly who in town I will send people to because they have the time in the OR setup and the support staff in the OR to really do a good job, in the same way that I have the setup in the clinic and the lab in my surgery center for doing advanced hysteroscopy to be really good at that. So if your surgeon or your REI is saying, look, I want you to go see XYZ person, there's a reason for that. And like Susan said, first do no harm. And we want to make sure that you get the care that you need. And sometimes that means, okay, I want you to go see this doc, and then you come back and see me after your surgery, bring your op note with you, and then we'll make the next decision that makes the most sense.
Yeah, and I would say too, before people were really trained to do minimally invasive surgery, before that was really kind of almost like a subspecialty. A lot of times, like earlier in my career, I would operate sometimes with a GYN oncologist because they're kind of geared toward doing really big, aggressive surgery. And even the GYN oncologist would say, doing endometriosis surgery is some of the hardest surgery that we do. It's just a really tough surgery. So the key point is, like Carrie was saying, you want to make sure the right person is doing your surgery. You don't want somebody just to go in and look and go, yep, you got endometriosis here, and so ultimately I think it's probably good to listen to your OBGYN or your REI if they want to send you to somebody else. Like Carrie said, there's a reason for that.
And I know the surgeons that I work with, sometimes it's people within my practice, sometimes it's people outside of my practice,
Yeah.
Kind of depending on the specific needs and timings and location and things like that. But know that we're working with these people. We're not just having you be sent to them in a vacuum. It's like, especially if it's somebody outside of my practice, I'll be like, if you see this, then make sure that this happens, especially like the hydrosalpinx conversation.
Yeah. Make sure the tube comes out for sure.
Exactly. So, sometimes it takes a village, and that's okay. That's okay. We want you to get the best care you can get and get you from point A to point Z as quickly and as safely as possible.
All right. Well, to our audience, thanks for listening, and tune in next week for more. Be sure to subscribe and leave a review in Apple Podcast. We'd really love to hear from you. We're also on Instagram, Facebook, YouTube. Be sure and follow and subscribe. Stay updated on all things infertility related.
You can also visit fertilitydocsandcensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for the Ask the Doc segment, so don't hold back. We love to hear episode ideas, so let us know what you're thinking and want to hear.
And as always, this podcast is intended for entertainment, is not a substitute for medical advice from your own physician. All right, we'll see you next week. Talk to you soon. Bye.
Bye.
Bye, guys.